Okay, so today is going to be cardiac boot camp, and we're going to talk about not just cardiac meds, but we're going to talk about blood flow through the heart, cardiac conduction, and the coronary arteries. Three separate things that are happening at the same time, but if you understand them, then you understand coronary artery disease, CAD. You understand heart failure. You understand all the other possibilities like AFib, right? So here's where we're going to start, and we're going to kick it old school. We are going to start just looking at the heart. Oh, it rhymed. And so what I've got here is a picture of the heart, okay? And the top picture is a real heart, which is pretty cool. And the bottom picture is a representation of a heart, okay? And what we see here when we look at the outside of the heart, we see, let me move this picture up a little bit, okay, if I can. I'm actually going to make it a little bit bigger. There we go. So let's move it up. When we look at the heart, that is the outside of the heart. And what you see is, you can see in blue, always represented in blue, are the veins, right? That's blood flow back to the heart. And represented in red are arteries, right? That is the superior vena cava, which is the biggest vein in the body, goes right into the right atrium. That is the aorta, biggest artery in the body, right? And then on the outside of the heart's covered by a muscle, and it's the myocardium. The muscle has to work to make the heart beat because the blood is inside the heart, right? Well, how does it do that? It needs oxygen. How does it get oxygen? Coronary arteries, which are these guys. This guy right here, okay, the left anterior descending, or no, the LAD, that's the widowmaker. Why do we call it the widowmaker? Because if you get a blockage here, this is what feeds the left ventricle. If this is blocked and this part of the muscle can't get oxygenated blood, that means that the left ventricle can't pump blood. The left ventricle pumps blood to your body, your brain, your organs with oxygen in it. You're dead. That's an MI. That's a big one. And then this is the right coronary artery and the right circumflex. So these are arteries, little itty bitty teeny tiny arteries that feed the muscle of the heart. When you do stuff like exercise or walk fast or run or anything like that, your heart beats faster. When your heart beats faster, it's beating faster. The myocardium, the muscle, has to move faster. It needs oxygenated blood. If you have plaque inside these arteries because you've been eating McDonald's your whole life, which is not a good idea, then the blood can't get through as quickly, which means that the part that it feeds can't get oxygen, and then you have pain. That's angina. This is what hurts. The heart muscle hurts because it can't get oxygenated blood, okay? So that's one thing that's going on the outside of the heart. But wait, there's more, okay? We need to look at the blood flow. So we're going to look inside the heart, okay? And inside the heart, you got two sides, right side and the left side. Just remember, the right side pumps to the lungs and the left side pumps to the body. The right side pumps to the lungs and the left side pumps to the body. So when we look at this picture, we see, and we're going to do blood flow, okay? When the blood gets all the way down, as far away as it can, oxygenated blood, down to your tippy toes and your fingertips, it goes into the capillary beds, and then it goes into your veins. And your blood's got to travel back up to the heart to get to the lungs to get more oxygen and do it again. So it goes through all your veins until it gets to your vena cava. And the vena cava feeds into the right atrium. The right atrium, there's a valve called a tricuspid valve that has to open and shut. That lets the blood, boom, boom, go into the right ventricle. The right ventricle pumps through the pulmonary artery into the lungs. Boom, boom, left lung, right lung, okay? And that's where the blood goes to drop off carbon dioxide, pick up more oxygen, and it's got to come back to the heart. It does that through the pulmonary veins. So here you go, pulmonary veins, right? Pulmonary veins. and it goes into the left atrium, through the mitral valve, into the left ventricle, through the aortic valve, into the aorta, and into systemic circulation. When somebody has a heart murmur, what is it? Does anybody, if anybody knows what a heart murmur is, you can unmute your microphone and tell me.
Irregular heartbeat?
No, a heart murmur is a bad valve.
Is a whole.
A heart murmur is a bad valve. What you hear when you listen to somebody's heart, you hear S1, S2, lub dub, lub dub, lub dub, lub dub. If I have a mitral valve, which is right here, that's messed up, it's also called the bicuspid, but it's the mitral valve, right? If that valve doesn't fully open or doesn't fully close, you're going to hear lub stub, love stub, love stub. That sh in between, that's the bad valve. And what you're hearing is a bruit. You're hearing blood go backwards. Everything in your body is South Philadelphia. It's a one-way street. Whenever something moves backwards, you got a problem. And you're going to hear something or feel something or see something. It's a warning sign, like this isn't supposed to be happening right now, right? So that's what a heart murmur is, right? A heart murmur is the problem with one of the valves, and it's usually the mitral valve or the aortic valve, okay? That they're either insufficient or there's a problem with, right? The number one reason for a mitral valve problem is rheumatic fever as a child. That's a board question. Make sure you know it. Rheumatic fever. If you've had rheumatic fever when you were a kid, it's going to do damage to the mitral valve. When you're older, mitral valve prolapse. And don't worry about prolapse or regurg or stenosis. We don't need to get into that right now. Just know, mitral valve's fucked up. AFU, right? It's a problem. And when it's a problem, blood will flow instead of moving forward, right? From the left atrium through the mitral valve to the left ventricle. That valve either doesn't shut right or sticks open and blood goes backwards. Oxygenated blood goes backwards into the left atrium. Whenever there's a problem inside the heart, right, depending on what side it is, right, that's going to show specific symptoms. So when we say heart failure, what we mean is that either the left or the right ventricle, and for lots of reasons, it could be because of the mitral valve problem or a tricuspid valve problem, but the ventricle, one of them or both of them, can't pump. Well, boom, because it's got to go whoosh and then refill, whoosh and then refill, whoosh and then refill, lub dub, right? So with heart failure, if my left ventricle fails or is failing, I can't get enough oxygenated blood into my aorta, to my brain and my everywhere. I am going to be short of breath, right? And my lungs are going to fill up with fluid. Why? Because if the blood's going backwards, backing up from the left ventricle through the mitral valve, the left atrium, it came from the lungs. It's going to back up into the lungs. Pulmonary edema, you're going to hear crackles, right? I am not going to be able to sleep in a flat position. I'm going to be short of breath. And when you listen to my lungs, you're going to hear fluid, right? And I'm going to have a cough. And one of the identifying factors is pink, frothy sputum. Left-sided heart failure, left-sided heart failure. It screams left-sided heart failure. Whereas if the right ventricle fails, now we got a different scenario because the blood's going to back up where it came from. So it's going to back up to the right atrium and back into the vena cava, which came from the body. My feet are going to swell. My ankles are going to swell. I'm going to get JVD, jugular vein distension, because the blood flow is going backwards to the body. So right-sided heart failure, symptoms are in the body. Left-sided heart failure, symptoms are in the lungs. If you got both, you got it all. Okay? How do we diagnose heart failure? So echocardiogram. An echocardiogram is just an ultrasound of the heart, okay? But we get one big piece of information from it, and that's the ejection fraction, and this you need to know. The ejection fraction is a percentage, a measurement of how much blood the left ventricle is able to push out into the aorta. And a normal EF, or ejection fraction, is somewhere between 50 to say 65 or 70%. If it's anything less than 50%, you have heart failure. Don't worry about what's going on if it's high. You'll get that when you go get your RN. Just worry about if it's low. So ejection fraction, anything under 50%, if you have an ejection fraction of 45%, you got some left-sided heart failure going on. If it's 20%, you can't walk to the freaking bathroom. You're short of breath. You're actually a hospice candidate if it's 20% or lower. Just that one thing would make you qualify, okay? So make sure you know, as far as diagnostics, ejection fraction, 50 to 70%, okay? Measurement of the left ventricle. It's lower than 50%, left-sided heart failure, okay? If you have left-sided heart failure and you have fluid that's backing up into your lungs, well, what am I going to do about it? What can I do about it? Well, I can do a lot of things, okay? I need to get the fluid out. Diuretics, right? Diuretics. And usually either furosemide or bumetanide. Furosemide or bumetanide, which are loop diuretics, right? And the big thing with loop diuretics, furosemide, Lasix, bumetanide, Bumex, they're the two you got to know, that they cause hypokalemia. They deplete your potassium. So you want to make sure the patient knows they have to get in plenty of potassium in their diet. To remember potassium, just remember the word potassium. P is for potato, O is for orange, T is for tomato, A is for avocado. Those are the food sources that are rich in potassium. And you want to make sure they're getting enough potassium, okay, in their diet so they don't become hypokalemic. So that takes care of getting some of the fluid out, right? But then we also have to treat, the problem with the heart. Usually what will happen is the heart will start trying to beat faster. Digoxin, the queen mother, right? Cardiac glycoside, digoxin, digitalis, lanoxin, all mean the same thing, digoxin. Digoxin is an antiarrhythmic. It works by slowing the heart down and makes the myocardium beat more effectively. It increases the contractility, the elasticity of the muscle, makes it go boom, boom, nice and slow, boom, boom. We need that pump to work better. That's why we give you DIG, okay? You need to know that with DIG, you have to have regular labs drawn. DIG level 0.8 to 1.2. Signs of toxicity, early signs, anorexia, GI upset, so loss of appetite, nausea, vomiting. Later signs, bradycardia, severe bradycardia. Why? Well, if DIG slows the heart down and you're toxic, it's going to slow it down too much, right? Makes sense. Dysrhythmias, it's an antiarrhythmic. Got too much in your system, you're going to get crazy rhythms. And then the visual problems like blurred vision, and then yellow or green halos in the visual fields. Okay, those are signs of toxicity. The antidote, easy to remember, Digibind. Okay, so that's digoxin. And with digoxin, the number one risk factor for dig toxicity is hypokalemia. So if you're on a loop diuretic and you're on dig, you really got to make sure sufficient potassium is in the diet, because if potassium levels start to drop, they're going to get toxic with the dig. And potassium, by the way, queen mother, if your potassium is too low or too high, it's got to be 3.5 to 5.0. If it's too low or too high, primary nursing intervention, get them on an EKG, call the doctor. I don't care what else. If they're calcium or their mag or their sodium, anything else could be screwed up. The priority, fix the potassium. Because if you're trying to fix some of the other electrolytes, they're going to have a heart attack. So you got to fix the potassium first. If I am hyperkalemic, I get K-exalate. You remember it because it's called K-exalate, and potassium's represented with a K. K-exalate gets rid of too much potassium in your blood. And if my potassium is low, well, you can give me potassium IV, right? So there you go. That solves that problem, okay? because you can have severe dysrhythmias. When you think potassium, you think muscle. When you think mag and calcium, you think nerves. Okay. So that's that. Let's talk about AFib for a minute. So the atria, you got one here and one here, left and the right. They're supposed to each at the same time contract and relax, pump and relax and fill up, pump and relax and fill up. They pump to the ventricles. Sometimes they go, you know what? We feel like dancing. And they go, blah, 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 blah. That's fibrillation. Atrial fibrillation. When the two atria are doing that weird dance, the blood will sit and pool inside because when they're fibrillating, they can't pump. And so what will happen is if blood sits, blood clots. A clot can form. If a clot forms here in the left atrium, and then the patient goes back to a normal rhythm, the clot's going to go zoom and move to the left ventricle. And then it's going to go zoom and get pumped into systemic circulation, and it's going to go for a ride. It's traveling. And it's traveling, and you don't know where it's going to wind up. If it winds up back here in a pulmonary artery or a pulmonary vein, that's a pulmonary embolism. Symptoms, I'm talking to you and I'm fine, and all of a sudden, so it's severe anxiety, extreme tachypnea with a sudden onset. What tests do we do? VQ scan. Okay, remember that. You need to know that. A VQ scan, which is ventilation perfusion scan, to diagnose if there is a pulmonary embolism in there, because we got to get it out or you're going to die. That is a life-threatening event. Right? So the biggest problem with AFib, the rhythm itself isn't going to kill you. Ventricular dysrhythmias will kill you. But atrial dysrhythmias won't kill you, but they can kill you indirectly with the clot. So we're going to put you on warfarin. And warfarin's an anticoagulant. It's only given orally. It's slow to work. The antidote for it is vitamin K. The lab work you have to look at is the PT, INR. INR 2.0 to 3.0, 2.0 to 3.0, 2.0 to 3.0 is the INR, therapeutic. PT is measured in seconds. PT stands for prothrombin time. The liver, right? What we're doing is we're counting it in seconds to see if there's sufficient prothrombin that will have the blood clot, or if we've slowed it down with the Coumadin, which is what we're trying to do, trying to slow down the clotting process. So it's an anticoagulant. It doesn't thin the blood. It slows down the blood's ability to clot, right? So PT in seconds, normal is like 9 to 11 seconds. So it should be, if you're on Coumadin, about 1.5 to 2 times that. So if it's 9 to 11 seconds, 2 times 11 is 22. So you're looking for a PT somewhere around 22 seconds. That means that your Coumadin level is good, okay? Now, there are 2 other anticoagulants that you need to know, heparin and enoxaparin. Now, heparin is given either sub-Q or IV. Heparin's the only one that can be given IV, and heparin is fast. If I give you IV heparin, you are anticoagulated within a matter of minutes. It's fast acting, okay? With heparin, you're looking at the PTT or the APTT. PTT is partial thromboplastin time. APTT is activated partial thromboplastin time. Say that 3 times fast. And that's measured in seconds. Don't worry too much about that. Just know that those are the labs that you look at. Don't ever ask the numbers for that. But what is the antidote for heparin? Protamine sulfate. Protamine sulfate, protamine sulfate, protamine sulfate. Okay, that's the antidote for heparin. So vitamin K, warfarin. Protamine sulfate, heparin. All right. So what else can we talk about? I'm going to talk about coronary artery disease and a cardiac catheterization, also known as an angiogram, but I'm going to take a quick pause. So I'm going to stop sharing for a minute and we'll be back in a sec. Okay, we are back again from our little short break. So a couple other things about heart failure before I finish up with that. When it comes to blood tests, the one blood test that you need to know that only has to do with fluid retention in the body is called a BNP. blood natriuretic peptide, and that's on the predictor. You're welcome. Merry Christmas. Happy Hanukkah. Happy Kwanzaa. Happy Arbor Day. Okay. BNP, and BNP should be under 100. Normal BNP, under 100. Make sure you know that, okay? That if it's elevated, that means that the person's retaining fluid somewhere in the body, okay? And let's see, what else? Well, let's talk about cardiac catheterization. So I am going to go back to my picture of the coronary arteries. Sure. Phone ringing. Do this. So with a cardiac catheterization, also known as an angiogram, and you need to know this, Mrs. Jones comes to the ER. I'm having chest pain. I took my nitro. Nitro, by the way, vasodilator. 1 tab under the tongue every 5 minutes times 3 doses. It's going to make your tongue tingle. That's good. It means it's working. You're going to get a headache. That's because the blood is flowing freely and it's rushing to your head. Take some acetaminophen. No big deal. Your mouth is dry. Wet it first or the tablet won't dissolve in your mouth. Don't make any quick moves, because if you do, you might fall over, because that releases blood flow. It opens up all your blood vessels. So the blood is just whoosh everywhere in your body. Blood pressure is going to drop a little bit. Okay. Make sure with nitro, it's got to be kept in a cool, dark place. It should never be kept in like a glove compartment in a car or anything like that, too hot. Replace the prescription every 6 months, whether you need it or not. And always keep it in its own bottle. Comes in a little brown glass bottle, right? Okay, so there was a little quick nitro in there. So Mrs. Jones comes into the ER. I took all 3 of my doses and it still hurts. What are we going to do? Well, the first thing we're going to do is we're going to put her on an EKG. We're going to stick some oxygen on her, right? And we're going to look at the EKG, because the EKG shows us the electrical activity from 12 different views of the heart. And as a matter of fact, let me pull up my short and sweet EKG stuff so that you can kind of, you know, see what it is. Let's see, cardiac rhythms. Is that the one? I don't believe it is, but anyway. So when we look at an EKG, we're looking at the heart's electrical activities from 10 different views. They call it a 12 lead, but it's really 10 views, and you've got grounds. So you're going to have an electrode on each arm, an electrode on each leg, and the rest of the electrodes are on the intercostal spaces, V1, V2, V3, V4. Okay. But what you need to know about an EKG is really just to kind of eyeball what the strips look like. Okay. And so I'm going to show you what the strips look like, and you don't need to know everything about them, but you do need to know some things. You need to be able to identify what is a normal. And I hate the word normal, but actually I'm going to go someplace different first. Onto the good old internet and show you a real strip. Okay, so bear with me 1 minute, because there are things on an EKG that you need to understand. Okay, and I am going to share my screen, and I'm going to make this the easiest lesson that you ever had in your life. Okay. In order for an EKG to be normal sinus rhythm, okay, there are things that have to be present. And the things that have to be present are a P wave, a QRS complex, and then a T wave. The P wave is all about the atria. QRS is all about the ventricles, and the T wave is all about everybody relaxes and we do it again. So when you look at this one piece, this is lub-dub. That one piece is one cardiac cycle, lub-dub, okay? When you look at a strip, the strip has different leads and the things are going in different directions, right? It can be confusing. Don't worry about it. What you want to look at, if I just look at the first lead, right here, right? What I'm looking for is how far apart are those QRS complexes? If they're really far apart, it's bradycardia. Heart's going super slow. If they're really close together, it's tachycardia, right? I'll show you some examples of that so you can kind of see what it looks like. You'll get a question on the boards that will say, you know, look at the following strips and which one of these patients would you give metoprolol or a beta blocker to? And what you would see is, that's a good one, right? Except it's kind of small. There you go. That's a kind of a good one too, but that's not that fast. Let me find a better one. Beta blockers. When you hear a beta blocker, bradycardia, beta blocker, bradycardia, beta blocker, bradycardia. Okay, there's a sinus tach. There we go. So if my heart is going fast, you can give me a beta blocker and it's going to slow it down. They're not just for hypertension. Actually, they work on the blood pressure after. They work on the heart rate first. Beta blockers and calcium channel blockers slow the heart down. But remember I said DIG increases the contractility of the heart? They do the opposite. They decrease it, but for a different reason. But they do slow the heart down. So you look at this strip, see how close together these guys are? Lub dub, lub dub, lub dub, lub dub, lub dub. This guy needs metoprolol or propanolol or labetalol, law. Beta blockers are the LOLs, okay? So that's a sinus tach. They're really close together. Sinus tachycardia. If we look at bradycardia, sinus brady, it's going to be the opposite. Okay? Look at that. You see how far apart they are? That is sinus bradycardia. The heart is going super slow. A normal heart rate for an adult is 60 to 100 beats a minute. And just for the heck of it, a normal heart rate for a newborn is 110 to 160 beats per minute. So this guy, as an adult, has a heart rate of maybe 38. And don't worry about counting. No one's going to ask you those questions. But you would look at this and immediately, just at a glance, go, oh, it's sinus brady. How do I know it's sinus? Because there's a P wave and a QRS complex and a T wave every time. As long as those things are present, that's a sinus rhythm. And that's all you got to know. And this one is sinus brady because it's going super slow. Okay? All right. And by the way, sinus brady, the medication that we give to speed the heart up, atropine. Atropine is an anticholinergic drug. And the anticholinergics are the weird ones. That's a group of medications that apparently don't have anything in common when you first look at the group. Because atropine, cardiac med, is in there, right? So is tiotropium, which is a respiratory med. So is oxybutynin, which is for overactive bladder. Seems weird, right? There are a lot more. Scopolamine is an anticholinergic. But here's the thing. They all share dry mouth tachycardia, okay? Those are the two most important side effects of anticholinergics. Tachycardia. If you have a heart rate this slow, I want you to go faster. That's why I give you atropine, right? And fun fact, in hospice, atropine eye drops. Atropine, and this is a board question. Atropine ophthalmic drops are used in the mouth, you heard me right, to dry secretions, okay? But atropine is given IV to speed someone's heart rate up if it's going so slow. This heart rate is so slow, probably in the 30s, it's not beating enough to perfuse. And the word perfusion means got to get the blood with oxygen to the body and the brain and the organs and the skin and the cells and everywhere else. Got to move the blood. When a heartbeat is that slow, your patient is barely conscious. They're like, what? Probably a little cyanotic, right? Perioral cyanosis, which means around the mouth. You'll see blue around the lips because that heart rate is just so slow. It's not quick enough to get oxygenated blood everywhere that it needs to go, right? So atropine for that. Now, when we talk about dysrhythmias, right? These are the ones that you should be able to identify. So I'm going to put in VTach and VFib. Here we go. So ventricular tachycardia and ventricular fibrillation. Let me find a good. Here we go. Use this one. Not big enough. How about this one? Yeah, good. Okay. Remember I said with AFib ain't killing you. It'll kill you indirectly if you throw a blood clot, but it's not in and of itself. The rhythm's not going to kill you. Rhythm's going to get you. No, I'm kidding. The rhythm's going to kill you if it's in the ventricles, if that's where the dysrhythmia happens. Because the ventricles, not that the atria aren't important, but the ventricles are way more important because the left ventricle is the one that's pumping blood to your brain and your body with oxygen in it. And the right ventricle is the one that's getting that deoxygenated blood and sending it to the lungs to get more oxygen. Well, what can happen is the ventricles can go into this crazy rhythm. The top one is VTach, okay? With VTach, do you see a P wave? Can you make anything out, or does it just look like a little kid went, nah, 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 nah? Okay? VTach means the ventricles are going so fast that the atria aren't doing anything. They can't do anything. They just couldn't possibly keep up. And that will lead to this, which is VFib. Both of these rhythms will be pulseless. That's what you need to know. In other words, you're walking down the street and there's a guy laying on the sidewalk and you're like, well, I'm a nurse, let me help. And you go over, sir, are you okay? Everybody's done that in your CPR class, right? And he doesn't answer you. Well, it's ABC. You check his airway. And believe it or not, he's breathing. Well, now you check his pulse. And you're feeling, and you can't feel anything. Right? What do? You do cardiac, not pulmonary. He's breathing, so he doesn't need you to breathe into him. What he needs you to do is pound on his chest to make this stop. Because if he came into the ER, I would go clear and go bam, and hopefully shock him out of that rhythm. With VTach, ventricular tachycardia, ventricular fibrillation, the patient is pulseless because the ventricles are just going so fast, they're not pumping anything. And if the left ventricle's not pumping, you ain't got a pulse. Because what you feel when you feel a pulse is the left ventricle pumping blood. That's what you're feeling. So they're not going to have a pulse. And so they're going to need either to be shocked. In other words, they're going to need to be hit with the paddles, right? Or if you're on the street, you can do really hard cardiac resuscitation. In other words, as far as pounding on the chest, or you can do a precordial thump. And I've done this twice in my career, and it's so much fun to do it when somebody wakes up. It's like I saved him. And a precordial thump is you're punching him in the chest as hard as you can, like this, but with the flat part of your palm right here. Boom! And what you're doing is you're doing it manually because you don't have electricity in your body, right? And it works sometimes. And it's cool because they'll be like, ugh, and they'll wake and you'll be like, I saved your ass. Yay! Right? No better feeling. All right. So just know these two are pulseless and they need to be shocked. There's not a medication I'm going to give you right here that's going to fix this. And if the shocking doesn't work, guess what comes next? Asystole. So when you watch Grey's Anatomy, understand that it's not true to life. Oops. Because asystole is a flat line. That's what happens after the VTach and the VFib. That just means there's nothing going on. It's over. It's a wrap. And that's the easiest EKG. Just know there's got to be a P wave, a QRS complex, and a T wave for it to be a sinus rhythm. It's either sinus regular rhythm, normal sinus rhythm, sinus brady, or sinus tach. And then other than that, VFib, VTach, pulseless need to be shocked, right? And that's really what you need to know about that, okay? let's get rid of this and let's see if we have any questions from our peanut gallery. And I'm going to talk about antihypertensives in a minute. So let me stop my sharing and I'm going to pause my recording. There we go. All right, so now we're going to cover cardiac catheterization. So we're going to go back to those coronary arteries that I had up before, oops, which are right here. So back to, remember Mrs. Jones? She came in, so we looked at her EKG and she was in ventricular tachycardia, right? And we gave her some nitro IV and we got her back down, but now we need to know what's going on. So did she have a heart attack? I mean, I don't know. We need to find out. So we're going to do a cardiac catheterization, which is also called an angiogram. What that is we're going to bring you in and you will be awake for the procedure. You're not anesthetized. We're going to take a catheter, which is just a narrow tube, and we are going to insert it into a large artery, typically the femoral artery. And I want to get so you can see me again. There we go. So we're going to take this catheter and we're going to insert it usually into the left inguinal area, right here, femoral artery, big artery. We're going to feed it up that artery. And then while we're doing that, you have an IV and we're putting contrast dye into the IV because the contrast dye, when it starts to travel through the blood, will illuminate things. So you're on a table, you got a catheter in your groin, you got an IV in your arm, and we're looking at the screen above us as the nurse and the doctor's in there. And we're going into the coronary arteries, these guys, because we're looking for a clot or atherosclerotic plaque that can build up inside there. So if you have, an artery that's this wide, but you have all this plaque from all that McDonald's, it's now this wide. And so the blood can't get through. So we go in and we look. We look at all of them, but we always look at the left anterior descending and the right coronary and circumflex first because they're the big ones. So we get in and we look and oh no, right here, she's got so much plaque built up that it's about 55 to 60% occluded, which is not good. We get over here, there's some plaque and it's about 20% occluded. Two things are going to happen. For the 20%, we're going to put a stent in. And a stent is just a small mesh tube that we put in that basically pushes open the artery to let the blood flow through it. We do that right there and then while she's on the table having that catheterization, we put that stent in. But over here, 65% blockage. She needs a cabbage and not corned beef and cabbage. She needs a CABG, coronary artery bypass graft. And what that means is that we have to finish up and then we're going to send her to the operating room where we are going to cut open her chest. We are going to take a saw and saw open her sternum. Literally, and I got to turn this way, right? Literally, we cut you from right above the sternum to right above the umbilicus, right there. And then we take a saw and we have to saw the breastbone, the sternum. And then we put rib spreaders in and open your chest up. And then we have to take a blood vessel from your leg. That's called a harvest. We take a blood vessel from your leg and we graft it over here. If the blockage is here, we're going to take that new blood vessel above the blockage and graft it on here so that, and we're going to run it over here so that it's bringing blood flow to the part of the heart that wasn't getting any before so that you're not dead. Okay, so that's what we do. That's a coronary artery bypass because we're bypassing the blockage. Graft, we're grafting that new vessel over there, right? So we can restore the blood supply. Well, what do you need to know? Stuff that you need to know about cardiac cath and about cabbage. Let's backtrack to cardiac cath. Always ask the patient if they're allergic to iodine or shellfish, because we use contrast dye. Contrast dye is used in cardiac catheterization, angiogram, intravenous pyelogram, which is for the kidneys, IVP. And if the patient's allergic to shellfish or iodine, they're going to have a reaction to the contrast dye. Oh, and CT scans with contrast, use that same contrast dye. And so if the patient's allergic to iodine or shellfish, can't have contrast, okay? You need to know that you're going to instruct the patient when they go in for that cardiac cath, they're awake, the room is cold, the table will move, because when the dye is going into their vein, we move the table to help the dye move quicker, right? It's very cool to watch a cardiac cath, very cool. So table's going to move, and when the dye goes in, they're going to feel this rush of warmth. The dye makes you feel like flushed, okay? So, and they're awake, and after the procedure, this is one of 2 times where I will tell you, don't move your patient. Otherwise, get them up. I don't care what they had done. Early ambulation. But cardiac cath and lumbar puncture are the 2 events. They got to stay supine 4 to 6 hours. With a cardiac cath, they need to have a pressure dressing at the site. They need to have a sandbag or even 2 sandbags over the pressure dressing, because we went into a femoral artery. It's a big artery. We don't want them to bleed out, right? And your job as the nurse is to assess distal blood flow. So if I had the cardiac cath in my left groin, you're first going to my right foot to check cap refill, color, temperature, right? And pulse. That's your baseline. Then you're going to the left, the affected side, and checking those same things. If my right foot is warm and my left foot is cold, that's a problem, because I could accidentally have done some damage and cut off the blood flow to that patient's lower extremity. That's what we're worried about. That's why you're checking distal pulses, distal cap refill, distal color, and distal temperature. So you're feeling for both feet should have the same temperature. If one foot is cool, they should both be cool. If one is warm, they should both be warm. Capillary refill, less than 3 to 5 seconds. That's the only time it's a little different, right? Less than 3 to 5 seconds. You should be able to palpate a pulse. And just because I have to do this, the dorsalis pedis, also known as the pedal pulse, is the one on top of your foot. And then after that, and this I have to go through because I find that people don't know the pulses. So let me back up some, back here. So you've got, I can get my foot up there. Dorsalis pedis is on top of the foot. Behind the ankle is the posterior tibial. Posterior tibial. Behind the knee is the popliteal. At the groin, right? Femoral. Carotid. Radial. Oops. Radial. Brachial. You need to know all of those. And you need to identify them. The predictor and the board will sometimes say, can you please, give you a hot spot and move the cursor to the dorsalis pedis. And here's another fun fact. When you're talking about the foot, and you should know directional, proximal is close to, distal's far away. Anterior is the front, posterior is the back. Also could be called ventral and dorsal, front and back. Except the foot. Except the foot. The bottom of your foot is the plantar surface, not the dorsal, right? And the top of your foot is the dorsal. Even though the dorsal is the back of your whole body, not your foot. Not your foot. Okay? That's why the pedal pulse is the dorsalis pedis, the dorsal part of your foot. And the bottom of your foot is the plantar. Just think about plantar fasciitis, which for some reason everybody got that. All right? So that's what you need to know about your job as the nurse taking care of that post-procedural patient with the cardiac cath. Now, the cabbage lady. Let's go back to poor old Mrs. Jones. She got through her surgery all right. We go in post-operatively. She will have an incisional site at her mid-chest that's either stapled or new skin, which is like a crazy glue, right? Adhesive. But remember, underneath, we saw it open her sternum. Well, we wire it back shut. Takes a long time for that bone to heal. The incisional site will heal up pretty quickly usually, but the sternum takes a long time. So if you walk into Mrs. Jones's room and she sits and looks at you and you hear click, click, that's a sternal click. She probably bent over at the waist and messed up those wires. And now we have to bring her back to the operating room and fix that. So post-op care for a CABG patient, no 90-degree bends, just like with a hip, right? Don't bend at the waist because you will pop the sternum. You don't want that to happen. They can't lift anything greater than 5 pounds. Did you know a gallon of milk weighs 10 pounds? Okay. So they can't lift that. And they should go to cardiac rehab. And the things that you're looking for as the nurse, you're checking the incisional site, of course, to make sure that there's not purulent drainage, which is pus. Don't say pus. We're nurses. We say purulent exudate, which means pus. Fun fact, I have seen nurses write the wound was P-U-S-S-Y. I don't know what you think that spells, but I know what it spells, and it's not pussy. So please don't do that. We're nurses. Purulent exudate, yellow, green. Infection, bad, okay? What would you expect to find? You would expect to find some redness, erythema, right? At the site, you would expect to find some serous drainage or serosanguinous. Serous is thin, watery, clear, or pale yellow drainage, normal. Serosanguinous is serous with a little tinge of blood in it, also normal. Okay? So that's normal, nothing to be concerned about. And no lifting, cardiac rehab, and of course, vital signs. And another fun fact, when it comes to delegation, you know, you don't delegate whatever you can eat. Evaluate, assess, teach, or treat. Can't delegate what you can eat. So if you need vital signs, are you going to have the aide check the vital signs on the CABG lady or the cardiac cath guy? No, because they're not stable, right? They can do vital signs on stable patients, but somebody who's a new post-op or post-procedure isn't stable. You want to do those yourself, right? Because you don't know what you're going to find. And if there's something amiss, the aide won't know what to do. That's why we need a nurse, okay? Okay. And, oh, and real quick, just to talk about like blood pressure too. Normal, and you know I hate the word normal. I hate it, because what's normal? Am I normal? Are you normal? Are you? No, I'm kidding. Anyway, so a normal blood pressure. The American Heart Association guidelines that have changed repeatedly over the years. When I started nursing, it was 150/80. Went down to 140/80. It's 140/70. The reason being that with a diastolic of 70, if you get upset or something happens, it could shoot up to 80 pretty quick. And the next thing you know, you could be in trouble. So 140/70 at your high end, right, of normal. What's the low end? The low end depends on the patient's baseline, as long as they're not symptomatic. But anything less than 80/40, you're very concerned. 90/50 is my norm, you know, but I'm not symptomatic. I'm not dizzy. I'm not blue. I'm fine. So if my norm is 90/50, then, yay, it's good. If my norm is 120/60 and you check it and I'm 90/50 and I'm like, God, I feel weak and dizzy, that's a problem. So that's clinical judgment. Clinical judgment. Understanding that one vital sign is not a whole patient. You have to look at everything. You have to look at your patient. Just like if you put a pulse ox on my finger and it says 74%, look at me. Do I look like my pulse ox is 74? No. So it could be that the batteries are bad. Could be that I got acrylic nails on, or it could be a lot of things. I could have Raynaud's disease and my fingers are so cold, you're not picking up, right? The point that I'm making is you look at your patient. And when you're doing an assessment, you got to get the whole picture, okay? Not just the cardiac, which would be the focused assessment, but then everything else as well, okay? And that's the moral of that story. I'm going to talk about antihypertensives real quick, kind of get them situated for you. Here's what you need to know. The true antihypertensives are the ACE inhibitors, which are the prils, the angiotensin II receptor blockers, the ARBs, which are the sartans, losartan, valsartan, and the aldosterone antagonist, and there's only one, and it's a eplerenone. They all lower blood pressure. That is their use. That's their indication. They are antihypertensive meds. All of them can cause hyperkalemia. They can all raise your potassium. So if your patient's on lisinopril and they're also on spironolactone, what would you be worried about? Hyperkalemia. Spironolactone's potassium sparing, and you know that the prils are potassium sparing. Now you're on 2 drugs making you hang on to K, you may be hyperkalemic, right? So they all cause hyperkalemia. Now the prils, the ACE inhibitors, can cause a dry cough. Now here's clinical judgment again. Is it a dry cough that's just an annoyance, or is it a dry cough that's keeping the guy up at night, right? So when would you call the doctor? If it's keeping the guy up at night, they need to be on a different med because now it's a problem. But if it's like, I got to tickle my throat to get this little dry cough here and there, that will usually subside. So you don't need to act on that, right? That's why when we say side effect or adverse effect, is it something that's an annoyance or is it something that will cause harm to the patient, right? And that's your clinical judgment is like, well, let me assess my patient and figure out which one, okay? So those are the meds for blood pressure. It's the ACE inhibitors, the ARBs, and aldosterone antagonists. So the ACE inhibitors are the prils, lisinopril, captopril, enalapril. Oh, and if you see, especially in ATI, they'll call it enalaprilat. There's an AT at the end. It's still enalapril. That's an old school name, like digitalis is to digoxin. Same drug, okay? So those are the prils. The ARBs are the sartans, valsartan, losartan, and then eplerenone. And the Board of Nursing is asking about that one for some reason, okay? That's like the flavor of the month or whatever. So make sure that you know eplerenone lowers blood pressure. It's an aldosterone antagonist, and it can cause hyperkalemia. The other thing to know for the prils, besides the dry cough and the hyperkalemia, don't give NSAIDs with any of the prils. So no ibuprofen, no meloxicam, no celecoxib, no naproxen. Those are your 4 NSAIDs, okay? Okay, then we have the beta blockers, and remember we went over them. They're the LOLs, metoprolol, propranolol, bisoprolol, labetalol, LOL, laugh out loud. They all cause bradycardia first, okay? And heart failure is a potential adverse effect. And then hypotension at the end, right? Beta blockers, bradycardia, heart failure, okay? Calcium channel blockers, bradycardia, right? And calcium channel blockers, the most popular one is amlodipine, also known as Norvasc, right? Because again, calcium channel blocker, beta blocker, they work on these cells that go around the myocardium. So it's the heart first, then the blood pressure, okay? And those are the antihypertensive meds. So we've covered those. We covered nitro. Real quick, the anti-lipidemics, okay? Statin drugs, atorvastatin, simvastatin, statin. Staten Island, no. Statin drugs are the statins and they lower cholesterol. But the big thing you worry about with all the statins is rhabdomyolysis. Patients on a statin and they have a new onset of muscle cramping, muscle pain, or muscle weakness, stop the drug, call the doctor. Rhabdomyolysis will kill you. It's a deterioration of muscle tissue that spills a certain enzyme into the bloodstream, and then you're going to check out. So if the patient experiences muscle pain or muscle cramping or muscle weakness after they start that drug, stop the drug, call the doctor. Could be a life-threatening event. Also know statins should be taken at bedtime, and you should never take them with grapefruit juice. And as a matter of fact, grapefruit juice, pretty much most medications don't like grapefruit juice, except ferrous sulfate. Iron loves grapefruit juice or orange juice because ferrous sulfate likes vitamin C, but statins do not. Then you have niacin. Niacin is vitamin B3 that has anti-lipemic properties. We'll usually give niacin with a statin because if somebody's really got a problem with their cholesterol. And by the way, normal total cholesterol, 200 or less. HDL, H is the good cholesterol, think healthy. It's high density lipoprotein, should be greater than 60. Low density lipoprotein, bad cholesterol, bad, the one that gets all gunked up in your arteries, should be less than 100. Total cholesterol, 200. LDL, the bad guy, under 100. HDL, the good guy, higher than 60. Okay, that's what you need to know. If I'm giving you niacin, which is just vitamin B3, with your statin, you're going to go, boy, I take my pill and I get this flushing hot feeling. Side effect, no problem. Take one 325 milligram aspirin 30 minutes before you take the niacin, and you won't have the side effect. The end. Okay? You'll be fine. Those are the kinds of questions that you'll get asked about niacin or about the statin drugs. Okay, so we covered the statins, the anticoagulants. I don't know if I talked about enoxaparin. I don't think I did, but let me just tell you. Enoxaparin, like heparin, enoxaparin's Lovenox. It's low molecular weight heparin. It's only given subcutaneously, and it's usually the one we use for prophylaxis. So you went in because you broke your hip, we did surgery, you're not moving as much as you normally do, I'm gonna give you some enoxaparin just to make sure you don't throw a DVT, right? So that's enoxaparin, right? And then we have antiplatelet aggregators, clopidogrel and aspirin. They're not anticoagulants, but they do slow the clotting process down from a different angle. They slow the clotting process down from the platelet perspective, where the others, warfarin and heparin and enoxaparin, work on other factors, okay? So just know, with bleeding precautions with all of them, use a soft bristle toothbrush, use an electric shaver, not a razor. Don't run with scissors because it's dangerous. Wear a medic alert bracelet if you're on an anticoagulant. That's important because if you come into the ER and you're unconscious, and this is a question, right? Patient's unconscious, if they have a medic alert bracelet on, and I know they're on warfarin, I can give them vitamin K if I got to do surgery on them and save their life, right? Otherwise, I'm waiting for lab results. I'm like, geez, I drew blood and she won't stop bleeding. I bet you she's on an anticoagulant. I don't know, let's guess which one. So, you know, medical alert bracelet's important. Home safety is important with the throw rugs and the electrical cords and those kinds of things. Stairs should be either, you know, highlighted with tape or something or lighted so the patient can see. Because if you're on an anticoagulant and you fall and you hit your head, you can have a subarachnoid hemorrhage. In other words, you can bleed into your brain. And we can't see that when it happens. Usually it's slow bleed. And so the patient falls, they hit their head, but they're like, oh, I'm fine. Lady's on warfarin. That night you go in and she's not breathing anymore because of that slow bleed, right? So anytime you have a patient on an anticoagulant, if they hit their head, please send them out just to get a CT scan or MR, just to make sure that there's, you know, no problems there. That's why home safety is so important if they're on anticoagulants, okay? They should use a soft bristle toothbrush so their gums don't bleed. Check the urine for hematuria. Check the stool for either frank blood, which is red blood, or melena, dark black tarry stool. It's a sign of a hidden GI bleed, which can happen, right? Petechiae, little red marks all over the place, signs of bleeding under the skin, problem if they're on an anticoagulant. Unvalidated ecchymosis. Ecchymosis are black and blue marks. I don't know why I got all these black and blue marks all over my arms. Did you bang into something? No. Right? Check their labs. Maybe their INR is too high, right? So that seems all like pretty common sense. And we already talked about what the antidotes are for them. I think that that's good with cardiac and with most of the cardiac meds. I'm going to pause and see if anybody has any questions or special requests. So see you in a minute.